From today, we'll be talking about different pathological conditions which are related to the spleen. And particularly in today's lecture, we'll be talking about the splenic infarction and the aneurysms. But before going into the detail of the pathology or going into the different disease processes which are happening in the spleen, before that, you should know a little bit about the anatomy and the surface anatomy, the location, and physiological importance of the spleen. So if we talk about the spleen, it is considered to be an important lymphatic organ because 60 to 66.5% of the spleen is consisting of the B cells and the T cells. And we all know that actually the B lymphocytes and the T lymphocytes, they are meant for producing the different components of the immune system, especially if we talk about the T lymphocytes. They are particularly important in the cell-mediated immunity. And if we talk about the B cells, so they are most commonly, they give rise to the plasma cells, and the plasma cells then produces the antibodies, and the antibodies are actually going to do the antibody-mediated immune function in the body. So if we talk about the location of the spleen, it's in the left hypochondrium, because we all know that the right hypochondrium is occupied by the liver. So the left hypochondrium is occupied by the spleen. So if you could appreciate in this diagram, this is the central part of the abdomen, and these vessels, the common iliac vessels and the vena cava, they are located just in the center. This is the descending abdominal aorta, and we know that the descending abdominal aorta is giving different branches which are not only supplying the important structures within the abdomen, particularly the small intestine and the colon, but also supplying some of the branches that are coming and they're supplying the liver and also the spleen as well. So if you could appreciate, this is the vena cava and this is the abdominal aorta, which is at the level of the first lumbar vertebra. It divides into right and the left common iliac arteries. And behind this is the psoas muscle, and we know that the psoas muscle is very, very much important. The only intra-abdominal muscle which is located within the peritoneum, and the vessels are resting over the psoas muscle. And we have the kidneys, and because the branches which are directly coming from the aorta, they are entering into the renal pelvis. So the right renal artery and vein and the left renal artery and the vein, and on the superior surface of the kidneys are the adrenal glands. So actually, if we talk about the spleen, it is in the left hypochondrium, or you can say it's extending between the like the space, starting from the gastric fundus and occupying the left hemidiaphragm and extending to the 10th rib. So usually, in case of the abdominal trauma, when the patient is giving you the history of abdominal trauma to the left hypochondrium, you suspect a splenic injury. And because spleen is very, very much vascular and profusely supplied, and it bleeds profusely, so any trauma or any injury to the spleen can lead to massive bleeding, which at times becomes difficult to control, and ultimately it ends up with the splenectomy. So moving back to a little bit about the surface anatomy, you should know that it's occupying the left hypochondrium, and it's in the left hemidiaphragm, and it's extending to the 10th rib. So in some people it's like 9th rib, and in some people it's 10th rib, but usually 9th and the 10th rib, a little bit of variation other than that. So if we could see, the spleen has got a notch, which is the inferior lateral surface of the spleen, and this notch is palpable whenever you are palpating the spleen having a splenomegaly. So this inferior lateral notch can be palpated. Now, talking about the blood supply and the lymphatic drainage and the venous supply of the spleen, you should always remember the vessels are entering into the hilum of the spleen. And we know that the abdominal aorta is giving three important vessels or arteries, like the celiac trunk, or you can say the celiac artery, then you have the superior mesenteric artery, and then you have the inferior mesenteric artery. You can also see here in the diagram, this is the location of the celiac artery, and usually it arises at the level of T12 vertebra. And then you have at the level of L1 vertebra, you have another important vessel which is coming from the abdominal aorta, which is called the superior mesenteric artery. And at the level of L3, this is actually the point from which the inferior mesenteric artery is being originated. So we know that the celiac artery is giving multiple branches, the hepatic artery and the common hepatic, then left gastric artery, and they are the branches which are actually supplying the stomach. And some of the branches from the splenic artery, they come down all the way and they just pass through the upper surface of the body and the tail of the pancreas, and then they enter into the hilum of the spleen, making the much of the blood supply available to the spleen. Then you have the superior mesenteric artery, and the superior mesenteric artery is supplying most of the foregut, and the inferior mesenteric artery is the artery of the hindgut, and it's supplying the colon and the cecum and most of the parts of the large intestine. So mainly staying focused on the celiac artery. Celiac artery is a branch of the abdominal aorta, and then the celiac artery is giving important further branches, including the splenic artery, the common hepatic, and the left gastric artery. And the splenic artery then in terms give branches and enter into the hilum of the spleen, making profusely rich blood supply for the spleen. Then the question comes about the venous supply of the spleen. So if we talk about the venous supply of the spleen, it's again the splenic vein, and then the splenic vein combines with the superior mesenteric vein, and they combine together behind the pancreas and behind the second part of the duodenum. They combine together and they form the portal vein. And then the portal vein actually gets entry into the inferior vena cava. So there are multiple tributaries within the spleen. They combine together and make a larger vein, which is a splenic vein. And the splenic vein then combines with a superior mesenteric vein. These two veins combine together and they form the portal vein. And the portal vein then enters into the IVC. Then comes the lymphatic drainage, and most of the lymphatic because it's coming from the splenic artery, so the most of the lymphatics are going into the celiac nodes just along the stomach, especially the gastric fundus and the lymph nodes which are located the paraortic. So the paraortic and the celiac nodes, they make the much of the lymphatic drainage of the spleen. Now some people have got some accessory spleens, maybe 0.5 to 1% of the people has got tiny, small accessory spleens, and they're also driving their blood supply from these splenic artery and the branches, segmental branches coming from the abdominal aorta and the splenic artery. Then comes about the important function, like it's initially was considered to be the vestigial organ like the appendix, but now it's considered to be the important part, especially it's a part of the reticuloendothelial system. Okay, so when we talk about the reticuloendothelial system, the thymus, the spleen, they are actually important because the macrophages in the thymus and the spleen, they combat and they act as a first-line defense. So B lymphocytes and the T lymphocytes are also located in the spleen, and it's considered to be a part of the reticuloendothelial cell. The B lymphocytes are providing the antibody-mediated immunity, and the T lymphocytes, they are providing the T cell mediated immunity. Then the second most important function that is being performed by the spleen is the filtration. Now, what do I mean by filtration? Like, we know that whenever the plasma has got a cellular component and a non-cellular component, right? And the non-cellular component usually is like the bacterial products and the debris and the waste products. And if we talk about the cellular component, then the cellular component consists of the RBCs and the platelets, right? So what happens is, like, when all these things come to the spleen act as a filter, and it separates the cellular component from the non-cellular component, and it degrades the RBCs, red blood cells, into the different components. Like, especially we know that hemoglobin and the iron, so it actually pushed back the hemoglobin, or you can say in other words, recycle the hemoglobin and the iron into the plasma back. So because it's mostly concerned with the just the filtration and providing immune system. So much of the products are coming into the spleen, the cellular and the non-cellular. So important function of the spleen is the filtration. That's why in the conditions like the hereditary spherocytosis or sickle cell anemia or other infectious conditions like the infectious mononucleosis, there is a splenomegaly. Now the splenomegaly, it's because a lot of the pool is coming back to the cellular pool is coming to the spleen, and the spleen is, after filtration, the cellular and the non-cellular compartment. What it does is actually it's splitting the iron and the hemoglobin, and it's because causing a kind of the breakdown of the RBCs. So in the process of breakdown of the RBCs, the spleen is enlarged because of the hyperfunctioning, because there's a lot of as a result of the sickle cell anemia, because there's a proper shape of the RBCs which is distorted in the sickle cell anemia, and they are like there is a sickling of the RBCs, and because the sickling of the RBCs, when they pass through the sickle cells, when they pass through the splenic pulp, they do not have the tendency to squeeze, okay, and they are not flexible anymore, so they stuck within the pulp of the spleen, and the spleen then try to engulf them, break down them. And that's why, because of the hyperfunctioning of the spleen is also enlarged, and also in a broad spectrum, it's a part of the reticuloendothelial system. So this was about the different functions which are being performed by the spleen, and this was about the location, the blood supply, and the lymphatic drainage of the spleen. Now, coming to the little bit about the physiology of the spleen, this also somehow important, because there is a capsule. It's like the liver, it's the encapsulated organ, okay? So it is encapsulated by a thick capsule, and inside, if we talk about the parenchyma of the spleen, there are multiple vascular sinusoids, and then these sinusoids, they combine together to form the splenic vein, which combines with the superior mesenteric vein, and they form the portal vein. Then in between, if you could appreciate here, these are the vascular sinusoids, just like the sinusoids in the liver. There's a capsule, these are the vascular sinusoids, and they are tuberculae, which are actually increasing the absorptive surface of the spleen, and they have got a number of the lymphatic channels within them. Then the main thing is the red pulp of the spleen. Then you have the hilum of the spleen, okay? So this is the hilum of the spleen, in which the splenic vein and these actually sinusoids, they are draining into the veins, and they combine together, the tributaries, and they form the splenic veins. Then you have the splenic artery, which is getting entrance into the hilum of the spleen and giving branches all the way together to the spleen. Then this is the inferior-lateral surface of this is the inferior-medial surface of the spleen, and this is the inferior-lateral surface of the spleen. And I told you before that at the inferior-lateral surface of the spleen, there's a notch, okay? So this notch is actually can be palpable when the patient is presenting to you with a splenomegaly. So this was about the physiology of the spleen. Now comes the important investigations, like if the patient is complaining about the left hypochondrial pain, or you are suspecting any kind of the maybe like a sickle cell anemia, or you are suspecting hereditary spherocytosis, and on examination there is okay, the patient is anemic, and plus if you palpate there's a splenomegaly, then you need to investigate why this is happening, because splenomegaly can be because of the infectious process, it can be because of the the aneurysm, or it can be because of the TB or infectious mononucleases or immune thrombocytopenic purpura ITP. So you need to go for some investigations, and you need to start from very baseline level, and you need to blood CP, and because the blood CP is going to tell you about three important things. The hemoglobin level is important and significant in case of the splenomegaly, because if there's a hereditary spherocytosis, or there is a sickle cell anemia, okay, or the hemolytic anemias, because hemolytic anemias there is a splenomegaly. And in case of the thalassemias as well, the HB level also drops down, so that's important. Then you have to look for the TLC count, because the myeloproliferative disorders, especially myelofibrosis and different kinds of leukemias and lymphomas, their spleen can be enlarged. So you think about those things as well. And then you also need to look for the hematocrit level, and you need to look for the retic count, and you need to look for the platelet count as well. The platelet count, because if it's immune thrombotic thrombocytopenia, then obviously you will be getting some kind of information from the platelet count as well. So blood CP is very, very much important, and obviously the retic count also becomes important, because when you're dealing with hemolytic anemias and the thalassemias, like hereditary spherocytosis and sickle cell anemia, then you think about these things. Then immune mediated thrombocytopenia, or ITP, in which there is an immune system activated, and they are actually engulfing the platelets, and as a result the spleen gets enlarged, and because ultimately you need to end up in the splenectomy. So you should always start from very, very baseline investigations. Then comes the radiology. But honestly, radiology is a kind of a supportive investigation in case when you're suspecting any pathology, really, because when you are thinking about some infectious pathologies or myelofibrosis, or you're suspecting about the hemolytic anemias and thalassemia, your diagnosis would be based mostly upon the biochemical profile instead of the radiological imaging. But radiological imaging becomes important when you're suspecting the aneurysm, when you're suspecting about, you just need to look for the size of the spleen, and you need to check. Usually the size is 10 into 7 into 5 centimeter, and if it's enlarged, it can vary. So ultrasound can give you a little bit about information about the splenomegaly. Okay, so then you move to the CT scan, and CT scan is a contrast enhanced computed tomography, and it helps in case when you're suspecting the splenic aneurysm, or you want to check about the vascular occlusion with the splenic vein, or you are suspecting some occlusion in the splenic artery which is leading to the infarction, or you're suspecting the aneurysm, then the CT is actually going to help you. So if you could appreciate, this is the picture of the ultrasonography, and this is the level in which you can identify the spleen. And usually, because spleen is a dense organ, so it would be hypodense in case of the ultrasonography. And ultrasound can only give you the information about the size of the spleen. It can tell you about the splenomegaly. But if you further want to investigate about the condition of the splenic artery, or you want to think about the splenic vein, then you should go for the important investigations of the like CT, the contrast enhanced CT scan, and sometimes Doppler can also help in case when you're suspecting some kind of occlusion with the vein or the artery. Then comes the CT. It is the most single important investigation, which is going to give you a lot of information. Okay, so this is the CT scan of the abdomen at the level of the liver and the spleen. So this is actually the liver, and this is the part of the spleen. And you can see here, actually, that these are the different pulps and sinusides which are located in the parenchyma, and you can see the whole architecture as well, the thickness and the splenomegaly, and you can also see the hilum of the spleen. You can see if there is occlusion in the splenic artery or not. So CT again become important investigation, single most important investigation. Sometimes magnetic resonance imaging, because MRI is, more sensitive to the soft tissues, so it can actually give you more of the information if there are some kind of the parenchymal changes to the liver, and their parenchymal changes in the spleen, so it can help you in either way. So there's a segment in which you can see the liver with its vascular sinusides, and you can see at the level here the splenic pulp and the parenchyma, and you can see a dense enhancing a lesion which is present at the upper part of the spleen. So MRI can be important sometimes when you are suspecting maybe the metastatic lesions into the spleen, or some kind of lymphoma, or the myelofibrosis or myeloproliferative disorders. Then comes the radioisotope scanning. So the radioisotope scanning is usually helpful in the conditions in which you see if there's a RBC destruction and there is hemolysis, and you need to see if the spleen is the cause of that hemolysis. So you need to give the radioisotope, and the isotope which is being used is the technetium-99, and you give this scan which is taken up by the splenic cells, and you can see if the RBC destruction is because of the splenomegaly or hyperfunctioning or hypersplenism, that can lead to the hemolysis. So it's an important single investigation, radioisotope scanning, in which you differentiate the cause of the hemolysis, whether the RBCs are hemolyzed, the spleen, or the spleen is a culprit behind that. So start from the baseline investigations, check for the symptoms of the patient. If you're trying to investigate anemia or thalassemia, then you need to, first of all, you need to go for the blood CP, and the single most investigation that's going to help is obviously the ultrasound, because it will give you if there is enlargement of the spleen or not. Then if you want to differentiate the hemolysis is coming from anywhere else, explain the culprit behind that, so you go for the radioisotope scanning. And if you are more concerned about the splenic infarction, or you want to see about the splenic artery occlusion or the splenic vein occlusion, then you should order for the CT, especially the contrast enhanced CT. Now talking about a little bit about the congenital anomalies which are happening in the spleen. There can be multiple hematomas, which can, they are vascular tumors, and they are benign in nature, and they can get very much complicated when they bleed profusely. So usually if they are smaller in size and there's no risk for rupture, then hematomas are usually not life-threatening. Then there can be multiple splenic cysts, right? Just like the other cystic diseases, a cyst can be in the liver or the kidneys or spleen. So if a cyst can also be the incidental finding in the ultrasound, and if this cyst is less than 1 centimeter, it's not causing any kind of the discomfort or kind of the symptoms, then you don't have to do anything for the splenic cyst. And then splenic so splenic are the small accessory spleens which can be located anywhere, but usually they are located just around the main arterial trunk in the hilum of the spleen. So they are also not that much harm, or they are dangerous or fatal. The two important most conditions in case of the spleen are the splenic aneurysms and obviously the splenic infarction. So if we talk about the aneurysm is particularly a dilatation of the artery, okay, abnormal dilatation of the artery. So the aneurysm can be anywhere in the body, in where, especially in the larger vessels, or we talked about the abdominal aneurysms, we talk about the thoracic aneurysms, and we also talk about the aneurysms which are located in the peripheral vessels. So same, the splenic artery is actually the main artery which is coming from the celiac trunk, and aneurysm can be a true aneurysm and a false aneurysm. So if you talk about the true aneurysms, so these aneurysms are, if they are not harming, or they are not they're not ruptured, so these aneurysms usually they are symptomless. They do not cause any symptom. But sometimes when there is a rupture of the aneurysm, then the patient goes, the patient becomes hypotensive and tachycardic as well, and the patient can have a very, very severe left hypochondrial pain, or the left upper quadrant pain radiating to the tip, because it irritates the diaphragm, because it's located in the left hemidiaphragm. So whenever it irritates the diaphragm, the pain is being referred to the tip of the shoulder. So talking about the splenic aneurysm, you should know what is the cause of the splenic aneurysm, because when we talk about the thoracic aneurysms, or you talk about abdominal aneurysms, you talk about increase intra-abdominal pressure, or you talk about maybe the conditions which are related to the loss of the elasticity, or the conditions like the collagen vascular diseases, especially the Marfan syndrome and the Allen-Delus syndrome, which is actually causing the thinning of the vessel wall. And because when the wall of the vessel is thin and atrophied and it's unable to resist high pressure, then aneurysms actually they are found. So in case of the splenic artery aneurysms, the cause is the intra-abdominal sepsis. The single most important cause is the pancreatic necrosis, or they can be a generalized cause, which talk about the arteriosclerosis and atherosclerosis. So we know that whenever there is some kind of process of the atherosclerosis and a cholesterol deposition in the artery, in the lumen of the artery, it's mostly the endothelium is the first most important layer. If we talk about the layers of the artery, so endothelium comes in the inner side, okay? Then you have the adventitia, then you have the media, and then you have the adventitia. So the innermost is the important one, which is in close contact with the cholesterol in the blood. So whenever you take a lot of the cholesterol in your blood, actually these cholesterol get deposited into the lumen, into the wall of the artery. And when these they are deposited on the vessel wall, what actually happens is like there is a lot of deposition of the cholesterol, and then they actually make the atheromas. So these atheromas, they harden the arteries, they lose their elasticity, and they become thin and atrophied. And this thinning and the atrophic character of the artery, they can lead to the aneurysm formation. Same happens in the pancreatic necrosis and the intra-abdominal sepsis, because a lot of the interleukins and the cytokines are released as a result of the infection and the sepsis, and they in turn cause the vasculitis of the vessels. And because whenever there's a sepsis means that the focus of the infection is in the blood. So we know that the arteries they are in contact with the blood. So because blood is running out of these vessels. So actually, this vascular foci, they are, or you can say the septic foci, that comes into the blood, and they can cause vasculitis. So whenever there's a vasculitis, the wall of the artery becomes thin, and it can lead to the aneurysm. Talking about this splenic artery aneurysm, usually if the aneurysm is small, okay, so it can be symptomless. It's quite possible there's no symptoms, but sometimes owing to the increase in intra-abdominal pressure, or in the pregnancy in which there's more more risk, or you can say if the patient is in DIC, then there is a chance of splenic rupture. So the patient can actually present to you with a splenic rupture, and when the spleen is ruptured, there's a lot of the fluid or your blood in the abdominal cavity, and the patient will obviously go into the hypovolemic shock, and the patient will be hypotensive, and he will be tachycardic, and he will be complaining of the generalized abdominal pain because of the fluid or blood in the abdominal cavity. And it can also lead to the fetal death if we are talking about the pregnant woman. So they can actually, the splenic rupture, and if the spleen bleeds massively, then this actually can lead to the fetal death, because it will lead to the hypoxia of the child, because the child or the fetus is actually getting the oxygen from the mother. Okay, so when a lot of the blood is lost within the abdominal cavity, there is less of the blood available for the fetus to gain. So that's why it goes into the hypoperfusion and hypovolemia, and it leads to the fetal death. Or there can be disproportion of the pregnancy. Now, talking about the diagnosis, if you are suspecting a splenic artery aneurysm, you always start from the history, the clinical examination, and you end up with particular investigations. So, if we talk about the the symptoms, so if the patient has already reported to you with this splenic rupture, then he would be having a generalized abdominal pain, and the patient would be toxic, and his pressures would be low, blood pressure would be low, and he would be tachycardic, and the pulse rate may exceed 120 per minute, and you suspect some kind of, you suspect, but maybe sometimes possible the patient already knows that he has got the aneurysm, and it's possible either way the patient doesn't know about the aneurysm of the splenic artery. So you need to investigate from where the patient is bleeding. So if you're trying to make the diagnosis for stabilize your patient and resuscitate as much as you can, and then if you have time, you have stabilized the patient, and then you have put the patient on fluid resuscitation and FFPs, and you have also put the patient on whole blood transfusions, and you have built up the patient, and you have a lot of time, then you go for the investigations. And investigations like the CT scan and the MRI, they can be helpful when you are trying to investigate a splenic artery aneurysm. Two most sensitive investigations, they're the CT scan and the MRI. And the CT is the contrast enhanced computed tomography, and it will actually tell you about it's possible that maybe there's one aneurysm, or there are multiple aneurysms, right? So the CT will actually going to help you with the diagnosis if there's a one aneurysm and it's bleeding, or other aneurysms along with that. And MRI can be also helpful, like in case of this, there is an enhancing lesion which can be aneurysm, and you can actually see. Then talking about the treatment, if the patient is toxic, and you know that he's already done his ultrasound and or the CT in the previous time, and you see that there was the splenic artery aneurysm, and you now suspect that the aneurysm has ruptured, and then you immediately think about the treatment. So the treatment always starts from resuscitating your patient. Resuscitation can be with the fluids, or resuscitation can be with the colloids. But the important thing is, because patient is going into hypovolemic shock because of the bleeding, so transfuse blood if you have available. So always send the cross match and the blood grouping, and demand blood as soon as possible till the time you put the patient on the fluids and the colloids and the crystalloids, especially the lactated drinkers. Then you go for the definitive treatment. So the definitive treatment is a splenectomy, because spleen bleeds very, very profusely. So you need to do the urgent exfoliate laparotomy, get rid of the splenic flexure and mobilize the spleen and just do the splenectomy as soon as possible. Because if you won't be doing the splenectomy, the patient would be keep on bleeding, and you may result in the death of the patient. So it's important if you're resuscitating the patient, but still he is not responding very effectively, that means it's still bleeding and massively bleeding within the spleen. Send for the HB as well, and just monitor for the pressures. And then the other thing is if you're suspecting the splenic artery embolism, then you go for the embolization and the splenic artery stenting, which can be with the interventional radiology or which can be with the cardiology. And then you also go for the laparoscopy, and the laparoscopy can actually tell you the exact site which is bleeding, and then you can convert it into the open surgery, and then you can see if there is any focus of the bleeding site, and you can deal with that, because spleen and liver, these are the two important structures which bleeds very, very massively. So when you come across these two important structures, any pathology, and you're especially coming across a splenic rupture, splenic artery aneurysm rupture, or the hemangioma got ruptured within the liver, or there's a massive trauma to the liver or the spleen, you need to open the patient and you need to get rid of spleen, which is the splenectomy. And you also do the splenectomy in cases of the thalassemia and the ITP, in which the spleen is the main culprit, engulfing and destroying a lot of the RBCs and leading to the anemia of the patient. So that splenectomy is also important indication for that. We'll be talking in a couple of lectures about the indications of the splenectomy, and we'll be talking about how you actually do this procedure, but in the other lecture. But for today, you should remember that if the splenic artery aneurysm is there and it's not symptomatic, then the patient is symptomless, then you don't have to do anything. Okay, you just wait. But you need to counsel the patient that anytime this aneurysm can be ruptured. So you need to counsel the patient and tell him the real situation. Then if the splenic artery aneurysm has got ruptured, resuscitate the patient with the fluids and the blood transfusions, and then immediately shift the patient to OR for splenectomy. So that's all for the splenic artery aneurysms. Another important thing we can encounter in case of the splenic lesions is the splenic infarction, and it can be secondary to myeloproliferative disorders. It can be because of the intra-abdominal sepsis. It can be because of the vaso-occlusion involving maybe because of the splenic artery occlusion, or because of the splenic vein occlusion. And if we are suspecting the splenic infarction, like, what do you mean by the infarction? It means that the arterial supply, especially the splenic artery, it's being compromised. Obviously, when the main supply of the spleen is being compromised, there would be no blood supply to the spleen, and as a result, there would be necrosis, and ultimately they would be the patient can be, because of the compromised blood supply, the patient becomes symptomatic. And in case of the myeloproliferative disorders, because there's a lot of splenomegaly, so actually that splenomegaly compresses the splenic hilum, and we know that the artery is actually entering into the spleen through the splenic hilum. So the occlusion can be from within the vessel, or it can be from outside, like the compression effects, okay, in case of the leukemias, lymphomas, and myeloproliferative disorders, and some kind of the infective pathologies in which there's a massive splenomegaly, and then it compresses these structures which are entering into the hilum of the spleen. It can actually lead to the splenic infarction, or infarction can be secondary to the vaso-occlusive processes happening in the artery. Secondary may be a thrombus formation, the atherosclerosis, or emboli. So embolism remains the single most important cause for the splenic infarction especially. So if you are suspecting a splenic infarction, how the patient is actually going to present to you. Again, the complaints would be the same: left hypochondrial pain, and the pain is, transmitting to the tip of the shoulder. If it's a right hypochondrial pain, that means the pathology is somewhere between the liver, and it's irritating the right hemidiaphragm, and the pain is being referred to the right tip of right shoulder tip. And if you talk about the left hypochondrial pain, so that means that the pathology is somehow related to the spleen, and then it's actually the irritation of the left hemidiaphragm, which leads to the pain in radiating to the tip of the shoulder. Now, if you are making a diagnosis, again, the contrast enhanced CT scan in MRI, these are two important investigations which can help you about the status of the splenic artery. So if you could see here in this diagram that this is the part of the section, CT scan, contrast enhanced CT scan, which is actually showing you the condition of the spleen. And if you could see here, this is actually the part of the spleen which is being infarcted, and you can see the condition of the vessels as well. So same here in this particularly, the spleen is only left to this focus, and rest of the spleen has already undergone into the infarction. The contrast enhanced CT scan can actually going to help you. Now, talking about the treatment, again, the treatment strategies would be like splenectomy, because if there's infarction, it can lead to the necrosis, and ultimately the patient goes into the sepsis. So in order to avoid that, you stabilize the patient, and then you go for the splenectomy in case of the treatment of the splenic infarction. Now, talking about the splenic rupture, so it can be because of the abdominal trauma. And mostly, if there is injury on the left side of the abdomen, or maybe the 9th or 10th rib is fractured, there's a gunshot injury at the level of 9th or 10th rib, you suspect a splenic injury. And then you order for you look for the clinical condition of the patient. If he is toxic or he is hypertensive, and you check for the tachycardia. And in the emergency situation, you go for the fast scan, which is focused abdominal sonography. So actually, you see if there is free fluid in the abdomen. If the patient is complaining you about the left hypochondrial pain, and you know that there's a history of trauma or gunshot injury on the left hypochondrium, and the patient is clinically not stable and is going into hypovolemic shock, and then and you see the free fluid in the abdomen, then you are done with making a diagnosis of the splenic rupture, which is the surgical emergency, and you immediately need to resuscitate the patient. Spleen bleeds massively, and you have to control the bleeding. So sometimes, just packing the spleen with a gauze for a considerable time becomes, if it's not bleeding that much, you can do the packing, and you leave the patient in ICU, and you reassess the patient after the 48 hours. And if it's bleeding massively, and it's becoming difficult for you to get the proximal control, or you identify the splenic artery, then what you do is you do the splenectomy, simple. The splenic rupture, the most important single investigation is a contrast enhanced CT scan. But if you don't have a CT scan available and you're setting and you're working in an emergency department, then the fast scan would be enough, because if there is a free fluid in the abdominal cavity and a patient is complaining about the left hypochondrium pain, then you suspect about the splenic rupture. Now, one cause for the splenic rupture can be the trauma, either the gunshot injury, the penetrating injury, the blunt injury, or some kind of RTA leading to this cause. But the other thing is a malarial splenic rupture, typhoid or malaria. So these actually can lead to the splenomegaly, and because of the enlarged spleen, there's a compression of the artery, and because if the spleen is massively enlarged, there is a chance that there is a parenchymal damage and the spleen may rupture. And again, the treatment would be the same, like resuscitate the patient and book the OR as soon as possible, and you do the splenectomy. So that's all for today's lecture. We have been discussing about the anatomy of the spleen, the physiology, the important function, and the blood supply of the spleen. Then we also talk about some pathological states which are related to the spleen, like the splenic artery aneurysms, their treatment, and the splenic rupture and their treatment. Thank you for today.